Hello, and welcome to the Chest Journal podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Matt Siuba.
Welcome to this month's edition of the Chest Journal podcast. My name is Matt Siuba. I'm a medical intensivist at the Cleveland Clinic in Cleveland, Ohio. I have the distinct pleasure to discuss a really interesting article with a great investigator today. The article is titled Evaluating the Association Between Patient Priorities and ICU Care Delivery in Adults Receiving Mechanical Ventilation. And I'm here with the corresponding author, Dr. Jacqueline Kruser. Jackie, thanks so much for being here today. For the sake of the audience, could you just give us a sort of a general introduction to who you are and where you work?
Great. Thanks so much, Matt, and thanks for having me. This is really quite an honor. So my name's Jackie Kruser. I'm a pulmonary and critical care physician at the University of Wisconsin in Madison. I practice here in our adult medical intensive care unit. And in addition to that, I work in a health services research program studying ICU care delivery.
Fantastic. And if you're not familiar with Dr. Kruser's work, please check out things that she's done in the past. They're really, really interesting and really relevant to the way we take care of patients every day, which is a great way to segue into our article. So can you, Jackie, give the audience an overview of what we knew about sort of goal concordance of care within the ICU and specifically around mechanical ventilation? What do we know about it prior to your study?
Yeah. So I think that part about goal concordant care in the ICU that is not complicated, or at least not contested, is that we all generally and pretty widely agree that it's a major goal of the care that we provide in the ICU. In other words, sort of experts and professional societies all are in favor of this notion that the care we deliver in the ICU to patients with critical illness, and even in the broader context of serious illness in general, one of our major goals is that the care we deliver ought to be aligned with what an individual patient's priorities are and what's most important to them. And so that is one of the key things we know, but it actually gets quite a bit more complicated after that fact and that level of agreement, which is to say that it's been very difficult to operationalize what this means, to study it, to measure it. So even though we understand that this should be one of the things we're trying to achieve in our everyday clinical practice, in our quality and performance improvement efforts, in our research, it's been very difficult to measure and understand what we mean by goal concordant care. The challenges here, probably everybody listening to this has some sense of what I'm about to say, but what we do know is that one reason it's hard to measure goal concordant care in the ICU is that it's a very dynamic clinical environment and there's a lot of uncertainties. So even with the uptake of advanced care planning and people who come to the ICU oftentimes, but not always, have completed advanced directives, those are static documents typically completed when they were not critically ill. So sometimes it's challenging to figure out how to apply those prior established and written directives to the dynamic context of an ICU stay. I think others have been looking at electronic health records as a way to measure and sort out and align and determine whether or not the care is delivered with is aligned with patients' priorities. But as we all know, the health records aren't necessarily designed for this purpose. In other words, to collect information about patients' goals, and that documentation is often inconsistent and incomplete. Other approaches to measure goal concordant care have included sending surveys to family members of patients who have died in the ICU and asking about their perspectives, which also adds a lot of value to this space and some understanding. But as we all might suspect, that these surveys are likely impacted by a recall bias and sort of an understanding after the fact that changes whether or not we think that the care delivered in the real time was associated with patients' priorities. And finally, I think a lot of this space and a lot of the work in this space has appropriately focused on patients who die. But I think it's also really important that we sort out whether the care that we're delivering is concordant with patients' priorities even when we survive. So I think having a broader notion of what it means to understand goal concordance amongst survivors and those patients who don't survive the ICU stay. So I think all of this is to say that at this point, we have pretty clear consensus that goal concordance is important, but a fairly limited understanding of how well we're doing as a field and as individual providers and at individual ICUs. And in acknowledging sort of all of this, I think there are some, the research that we do have suggests that the care we provide in the ICU is sometimes not concordant with patients' wishes. So something up to 10 or 15% of patients who are near the end of life might receive care that's not concordant with their wishes.
Yeah, that all really resonates with my clinical experience, and I'm sure a lot of the listeners too. So now that we kind of understand some of the challenges that existed and what we think we understand at this point, can you take us through the inspiration for the study question for this paper?
Yeah, so I think building off of that and building off some of the challenges that I've just walked through, we wanted to understand if it's feasible and what we might find if we were to elicit direct real-time patient priorities from patients in the ICU. And now, ideally, this would be directly from patients, but as we all know, a lot of our patients who are in the intensive care unit lack capacity and are unable many times to communicate with us about their treatment priorities. So in the clinical space, we're typically relying on surrogate decision makers or people who make decisions and represent the patient's priorities and interests when making medical decisions in the ICU. So in our study, we were seeking to conduct a prospective observational cohort study that evaluated the association between ICU care delivery and patient treatment priorities as defined by a real-time direct elicitation of these priorities from patient surrogates.
Yeah, that's a really interesting approach. And I understand this study was a sort of a secondary analysis of another study based on the patients with pneumonia. Beyond that, could you take us through sort of the basic overview of the study design?
Yeah. So as you said, what we were doing was we were embedding this study within an ongoing large-scale observational study of mechanically ventilated patients with pneumonia. And for surrogates who agreed to participate and enroll the patient in that parent study, during the study enrollment, we also used a standardized questionnaire and a set of questions that had been previously validated and used in the ICU space to elicit the patient priorities from the surrogate decision makers of patients in that study. And then after eliciting, for those patients in whom the surrogate agreed to participate in our patient priorities questionnaire, we measured how care was delivered in the ICU stay using electronic health record data. And in addition to asking about what the patient priorities were for the patient in the study, we also asked the surrogate whether or not they'd had previous conversations with the patient about their preferences around ICU care and life-sustaining treatments.
So once you were able to sort of compile all that information together, what did we learn? What were the key takeaways from this study?
So one of the pieces, and I'll sort of hone in on this here. So when we asked the surrogates, the patient priorities, we asked them to articulate those priorities into essentially three major categories. One being live as long as possible, even if that might mean uncomfortable medical procedures or treatments. And for our purposes, we labeled this preference or this priority category maximize survival. The second category that the surrogates had to choose from was to try and live as long as possible, but that the patient may decide that some uncomfortable procedures, treatments, or long-term life support would be unacceptable. And for the study purposes, we labeled this priority middle ground. And the third priority that the surrogates were asked to choose between was maximize comfort and quality of life, even if that meant the life was shorter. So again, the surrogates were asked to choose one of these three categories, and that last one we classified as maximize comfort. And so when we did the statistical analysis, which primarily was stratifying the sample into these three groups, again, maximize survival, middle ground, or maximize comfort, the major takeaway is that we did not find a strong relationship between the surrogate reported priority group and how care was delivered. So in other words, many of the aspects of the ICU care delivery and as well as the hospitalization outcomes were quite similar across these priority groups. So this includes interventions we would typically think of as inconsistent, for example, with a maximized comfort set of priorities, such as placement of a tracheostomy, which occurred in about 20% or 19% of the maximized comfort group and 23% of the maximized survival group. So again, unsurprisingly, we did not find a statistically significant difference between, in this case, just using this one intervention as a way to highlight the care delivery between these three groups.
Yeah, I think that was the most interesting result of this study, is just looking at how even, at least surrogate reported preferences maybe were not reflected in the care that was being delivered. Do we have any sort of hypotheses of why this may have played out this way?
Yeah, I think that's right. And amongst the author group, I think that was our interpretation and takeaway as well, that there was this lack of association between the three groups. And one thing that I wonder about, and I think our findings might point towards, is the strength of the underlying norms and routine processes of care that tend to dictate how we provide care in the ICU. And so one of our findings, I think, that nicely highlights this is worth discussing, is what we found about code status orders. So this actually was one of the differences that we saw amongst the three groups. And just to provide the listeners with the numbers, so we determined the admission code status for all of the patients in the sample. And the options based on the hospital's setting was either do not attempt resuscitation, a full code order, or a limited code status, which again, in this hospital system was do not attempt cardiopulmonary resuscitation, but that intubation would be okay for respiratory failure. And what we found in looking specifically at full code orders, so unsurprisingly, in the maximized survival group, 100% of the patients had a full code order at the time of ICU admission. And 95.2% of the middle ground group had a full code order, and 83.8% of the maximized comfort group. So that was a statistically significant difference across the three groups. But I think what's worth pointing out is the absolute value here. So among patients for whom their surrogate said their goal was to maximize comfort and quality of life, still almost 84% of those patients had a full code order coming to the ICU and were receiving invasive mechanical ventilation at the time that set of priorities was articulated, as according to our study design. And I think what this suggests is that probably for these patients in whom the surrogate was able to articulate this preference, the clinical team was probably unaware of this set of preferences for the patient. And instead, the patient is left with the default, which is a full code order, as most of us know. I think in almost all ICUs across the US and hospitals, that the default status in the absence of changing it otherwise would be full code. And so I think our findings, again, of the lack of association across these three groups, and then the really high frequency of these default set of interventions, suggests that there is a strong sort of default towards life extension at play.
Yeah, that's really interesting. And I think maybe something that's not quite captured here is, to what extent were the treating teams aware of these preferences? Did you have any sense of that? I'm guessing not.
That's right. Because of the observational study design, we only relied on what was reported in the electronic health record. And so we did not systematically elicit we weren't aiming to intervene. In other words, we weren't feeding back to the clinical teams about the observational information. So we do not know what the kind of conversations had been had between the surrogates, the patients, and the clinical teams. That's right.
Got it. Thanks for that clarification. Any other words of caution or limitations that readers need to think of when we're interpreting these results?
Yeah, I do think there's mostly what I took away from what I learned from this study was that we really need to keep thinking about how best that we still need a lot of attention in this space, and we need to keep thinking about how best to align the care that we're providing in the ICU with patient priorities. But knowing that this is a small study, so we had a little bit over 217 total patients included in the study. So it is very much possible that there are differences between these priority groups that were undetectable because of our sample size. And so I also think, and this was a single center study, and so I think it's also important to know that these findings may not reflect processes and norms of care delivery across the United States and might not be widely generalizable. And I do think we weren't, I hope that this study is a contribution to sort of this complex area that we outlined in the beginning of our discussion about measuring and understanding goal concordant care. But there still requires more work to determine whether or not the care that's delivered was truly concordant with the patient's wishes at that time. So I think we can sort of learn at the population level these broader patterns in care delivery. But I think ultimately our results should be interpreted as hypothesis generating and hopefully motivating for more work and more and continued efforts to improve how we incorporate patients' priorities and goals into ICU care delivery, and hopefully encourage ongoing efforts in this space.
Yeah, so that's a great overview. I appreciate that. Understanding where this is sort of a hypothesis generating study, I'm sure you have some thoughts about communication between care teams and patients or their surrogates. Any advice for either of those groups on how we might improve communication, make sure the things that we do are going to be goal concordant?
One thing that I've been thinking about a lot in this space is that the absence of communication is of equal, if not greater importance than an imperfect approach or underdeveloped communication skills. Because I do worry that in this absence and this blind spot that I think perhaps we all might have sometimes in our clinical practice is the space in which the assumptions and biases and the implicit default processes of care can really take hold. And so I think building on that, my advice would be to focus not only on what you say, but when you say it. And I think we ought to be communicating quite early with patients and their families, even when we're uncertain about the outcomes that are likely to unfold, even when we're uncertain about prognosis or what we think might happen for the patient, or even what we think the underlying cause of critical illness might be. I think upfront and early transparent communication with our patients when they're able and their surrogate decision makers when they're not may help mitigate some of the problems that arise in the absence of communication.
Could not agree more. Any final thoughts for our audience?
I think the one spot I would leave us to think about is that we've known for a long time in healthcare that the routines and the processes of care delivery and our systems of care are likely to have a greater influence on patient outcomes than individual human effort or error or individual clinician expertise or skill sets. But I think communication and studying goal concordance, we've for a long time focused on individual level decision making and communication, which I think is a absolutely the right focus, the right place to start, and work that ought to continue. But I do think what the findings of this study might help us think about more broadly is how we could also apply this notion of a systems lens and really understanding our routines and processes of care delivery and how and when we initiate communication as a way to help promote goal concordant care, in addition to all of the really important work about how we communicate and the skills in which we bring to each of those communication events.
Fantastic. That's a great summary. Thank you so much, Dr. Jacqueline Kruser, for joining us today as we're discussing this fantastic article evaluating the association between patient priorities and ICU care delivery in adults receiving mechanical ventilation. Thanks to you all for joining us, and we'll see you next time.